So you'll see a series of physicians up here giving presentations. We're used to giving presentations to other physicians. So we tend to speak fast. We tend to use big words. We tend to assume you know some of the things we're talking about. So if I'm doing that, please, wave your hand and say, what do you mean by that? I think we're all going to leave quite a bit of time for questions. I only have 14 slides, so about half my time will be for any questions you have about MEN1 in general. So we'll have lots of questions with each session. I'm just going to bring the lights down a little bit so that you can see these slides better. So MEN1, how common is it? Well, as probably most of you know, this is not a very common problem. About 20 people out of 1 million. When we're talking about rare medical disorders, I like to put it in perspective. Okay, how many people out of 1 million would have it? Now, we have other endocrine disorders that are even more rare than this, but this is pretty rare. And we teach in medical school that the way the medical students can remember the main components of MEN1 is the 3 Ps. P for parathyroid, P for pancreas, and P for pituitary. But as many of you know, MEN1 is more than just the 3 Ps. And this graphic is actually as a handout in the back, and you can pick it up at the break if you didn't get one. These are, and I'll be using several of these illustrations. These illustrations are from a medical book called Netter's Collection of Medical Illustrations. Frank Netter was a physician but an artist back in the 1950s, 60s, and 70s, and could do amazing paintings of people and anatomy and the medical disorders that people would get. This book was republished in 2011. Now, Dr. Netter's no longer living, so Carlos Machado is also a very talented artist, and he took over. So back in 1965, when this book was first published, no one knew about MEN1. So there were no paintings of MEN1. So this is a new painting that's been done. And I'll just highlight a couple of the components here. We'll just start at the top. So angiofibromas, these are small little skin bumps. They tend to occur around the crease of the nose. These are benign. Usually we wouldn't do anything with these unless it was bothering the patient. I'm going to actually talk a little bit more about the pituitary adenomas in some separate slides. Same thing with parathyroid hyperplasia and parathyroid adenomas. Thymic carcinoids, these fortunately are a rare component of MEN1. These many times are malignant, but this is why we occasionally will look at the chest. The thymus gland is in the front of the chest, right in the middle. Adrenal adenomas and enlargement of the adrenal glands, which we call hyperplasia, is actually quite frequent in MEN1. Fortunately, we usually don't have to operate it. Occasionally we do. I'll be spending some time talking about the pancreas and the duodenum. So these are the gastroenteropancreatic neoplasms. So that in the duodenum right here, you can get these little carcinoid tumors that make gastrin, which cause increased acid production in the stomach and predispose to ulcer disease. And then in the pancreas, here's the tail of the pancreas, and here's the head and uncinate process of the pancreas. They tuck right up into this S curve of the duodenum, and this is where we can get islet cell tumors, which I'm going to spend a little bit more time talking about. Lipomas are actually very common. These are benign fatty tumors that patients with MEN1 can get under the skin. We usually don't do anything with lipomas unless they're large enough that it's bothering the patient, then they certainly can be removed. But these can show up on arms, legs, back, torso. Cholangiomas are really small little bumps, but instead of occurring on the nose up here, these can occur other places in the body, like by your tummy button, umbilicus is a common spot for those to show up. They're benign, and again, we don't do anything with them unless they're bothering the patient. At the base of the esophagus, so this is the stomach and this is the swallowing tube, the esophagus, you can get esophageal leiomyomas, which is a benign tumor in the wall of the esophagus. And usually we wouldn't do anything with that either unless it got big. And when they're big, there's only so much room up here in the chest, and usually we'd remove them at that point. There's a spinal cord tumor that can occur in patients with MEN1, but this is fortunately quite rare, ependymoma. And the last part of MEN1 are bronchial carcinoid tumors. These are really small tumors that occur in the breathing tubes of the lungs. So what I'm going to show in the subsequent slides, I'm going to focus on the 3 Ps and not talk about these other less common components of MEN1. Any questions about this main graphic? We're actually going to use this graphic in some of the subsequent slides. So P for parathyroid. The parathyroid glands are next to the thyroid gland. So para means next to, so next to the thyroid. So the thyroid gland looks kind of like a butterfly. It's in the neck. And then the parathyroid glands are much smaller. They're somewhat embedded right next to the thyroid gland. And you're going to be hearing more about this from Dr. Thompson. So in MEN1, the parathyroid glands can be enlarged. That's called hyperplasia, or they can develop tumors, benign tumors, and those are called adenomas. And basically, we can never say 100% in medicine. We can never say 0% in medicine. But this is one of those things that, yeah, it's pretty close to 100%. Patients with MEN1 will have either parathyroid hyperplasia or a parathyroid adenoma. And these are benign, and benign means not cancerous. So I showed you in general where they are. Here's a Netter painting of the front view of the neck. So obviously the skin is gone. This up here, right there, that's your Adam's apple. So if you feel in your neck, that little notch, that's the Adam's apple right there. And you can see the thyroid is just below that. The thyroid has the consistency of mashed potatoes, so it's not like many people can feel their neck and say, oh, I can feel my thyroid. Usually it just kind of squishes right under your fingers. And as we look at this, and you look at everything that's labeled, the parathyroid glands are not labeled. They're hiding. And this is why when we're operating on parathyroid glands, you need a surgeon that has expertise on how to find them. So here's the side view of that neck. So here's that Adam's apple cartilage right here, and here's the thyroid. And the superior parathyroid gland is kind of tucked up here behind the upper lobe of the thyroid here, and then the inferior parathyroid down here. So they're really quite small, and they can be hard to find. So that's another reason to have an expert surgeon that has done this quite a bit. So when the parathyroids become hyperplastic, or if they have an adenoma, they make too much of their hormone. Their hormone's called parathyroid hormone. What it does is it tells the bones to release calcium. And so the blood calcium level goes up. How that works is it tells the bones to release the calcium, and then the kidneys try to get rid of the calcium. So there's increased calcium in the urine, and you're predisposed to getting kidney stones. And in the process, because the calcium is coming from the bones get thin. So this is a problem. So long-term, high blood calcium will cause kidney stones and thin bones, which is also called osteoporosis. So this is the reason it should be treated at some point in most patients. to prevent these long-term side effects of losing calcium from the bones. So P for pancreas, so gastroenteropancreatic tumors, or GEP tumors. And this is that graphic I showed you before. So the pancreas here fits right into the duodenum, and these are these little carcinoid tumors in the duodenum that can make the gastrin. And again, this is a very high percentage of patients with MEN1. Not all patients with MEN1, but a majority of them. And unlike the parathyroid, these tumors in the pancreas can be malignant. That means cancer. So this is Netter's drawing of the upper abdomen. Just identify a couple things for you. Here's the right kidney over here. Here's the left kidney. So we're looking at, this person is facing us. That's the right adrenal gland sitting on top of the kidney. Here's that S curve in the first part of the small intestine that's called the duodenum. And this is the pancreas in yellow. And so you can see it's actually quite large. It extends way over to the left side of the body, and that's called the tail. And then this is the body of the pancreas, the neck of the pancreas. And over here, the head of the pancreas fits right into the duodenum. And this part here is called the uncinate process. So when you hear about there's a tumor in the tail of the pancreas, that means it's over on this side here. And these, you're going to hear more about operations on the pancreas. Let's see, who's talking about that?
Smoot.
Dr. Smoot will be talking about pancreas surgery. And it's pretty straightforward for them to approach the tumors that can be in the tail. It gets a little more difficult with the tumors that are over here. There's more stuff going on over here in the head of the pancreas. So pancreatic neuroendocrine tumors frequently are non-functioning, meaning they don't make a hormone in excess. Or they can make excess hormones. One example would be insulin. And if it makes too much insulin, that causes the blood sugar to be low, and that's called hypoglycemia. And the tumor that makes too much insulin is insulinoma. And this is an old Netter painting of a patient with an insulinoma. When you make too much insulin, the blood sugar drops, the heart rate goes up, patient gets sweaty, might get a little confused. And then all those symptoms go away if that person gets calories, glucose, like orange juice. And so patients that have what's called Whipple's triad, which is low blood sugar symptoms in terms of brain function, the blood sugar's low, and then if they symptoms get better by taking in calories, that's all consistent with that person having an insulinoma. And there's just a painting of a pancreas, and here's a tumor in the tail of the pancreas, an insulinoma. Down in the bottom half of this painting, it's representing a patient with an insulinoma, but there's more than one, and it actually has spread. So this is a malignant insulinoma. You can see there's a spread right there to part of the liver. That's the gallbladder right there. And this is the stomach that's being pulled up because the stomach hangs down in front of the pancreas. So as I said, these pancreatic neuroendocrine tumors can be malignant, especially when they get quite large, like this one here. And the last P is P for the pituitary. The pituitary adenomas can be non-functioning, meaning they don't make a hormone, or they may make a hormone in excess. And the three are listed here: prolactinoma, so a pituitary gland makes 6 different hormones. One of them it normally makes is prolactin. The only use of prolactin in the human being is to prepare the breasts to produce milk. They do this through the last half of pregnancy, and then if a woman chooses to breastfeed, her prolactin levels remain elevated as long as she breastfeeds, and it tells the breast to make milk. It has no other function than that. Now, men have prolactin, but there's no function in men. But in the pituitary, you could get a tumor of any of the normal cells in the pituitary that make a hormone, and then you might have signs and symptoms of that excess hormone. and I'll show you that in a minute. GH stands for growth hormone. So the cells in the pituitary that make growth hormone, that's why we grow from childhood. It's because of the pituitary gland. It makes growth hormone, allows individuals to grow to normal heights. And so one of the causes of dwarfism is if the pituitary doesn't make growth hormone, then that person can't grow. So in patients with MEN1, though, a pituitary tumor might be able to make growth hormone. And if it makes it if it makes it in a child, that person will grow. That person will grow very tall. If it makes it after the bones have been fused, then it causes a syndrome called acromegaly. Pituitary tumor in MEN1 very rarely would make this hormone, ACTH. That's the hormone that tells the adrenal glands to make cortisone. And too much cortisone is a syndrome called Cushing's syndrome. So having said all that, usually the pituitary tumor in MEN1 is either going to be a prolactinoma or a non-functioning adenoma. About 20% of people with MEN1 will develop a pituitary tumor in their lifetime. So this is not as common as the parathyroid problem or the pancreas problem. And all these tumors are benign, in other words, not cancerous. So where's the pituitary gland? So this is another Netter painting. So you can see this is a side view of a person's head. So here's the forehead and here's the nose. So the pituitary gland is labeled right there. So it sits straight behind the bridge of the nose, right back here. So it actually hangs down from the brain on a little stem, and we call that the pituitary stalk. And the pituitary is actually not part of the brain. It's not brain tissue. It's actually a gland. It's a gland like the thyroid gland or the pancreas, which is a gland. We call it the master gland because it makes all those hormones controlling some of the other glands. If we look at a front view, so this painting is of a person who's facing us, but it's been cut right in front of the ears. So here's the brain on the patient's left side, the brain on the right side, and here's brain above the pituitary. Here's the pituitary right here. That's the stalk. These are the nerves to the eyes right here. So the reason I'm showing you this is some of the issues that patients can have if they have a pituitary tumor and if it enlarges. If it enlarges and grows north, it can push on the nerves to the eyes and cause trouble with vision. Or if it grows east or west, it can cause problems. This is like a big vein here, and here are nerves. These nerves control several things, but most of them control the movements of our eyes. Like when we look up or look to the right or look to the left, they control our eyelid being able to come up. So a pituitary tumor, although it's benign, can grow east or west and cause problems with the functions of those nerves. So when overactive, pituitary tumor can make too much of a pituitary hormone, and the one example I'm going to provide is a prolactin-producing pituitary tumor. So this would be a woman who has a prolactin-producing pituitary tumor. She's not pregnant. She didn't just have a baby, but the breast is producing milk. And the medical term for that's galactorrhea. So when a patient comes in and she has breast milk production for no known reason, it's usually because the prolactin level is high. And many times the reason it's high is a pituitary tumor. What's being shown over here is some of the symptoms a pituitary tumor can cause. If it's large, it can cause headaches. It can cause problems with those nerves that control the eyelids and control the movements of the eyes. Here are some MRI scans. So this is an MRI scan of a person with a small pituitary tumor right there. This person's standing looking at us, so the left ear would be over here, right ear over here, top of the head up here, chin down here, and this slices right through the pituitary gland. That black spot there is the carotid artery on the right, that's the carotid artery on the left, and there's a small pituitary tumor. So we call these microadenomas, meaning they're small, less than a ½ inch. And then if it's making prolactin, that gives doctors a real advantage in treating it. We don't have to treat with surgery. We can treat with a couple different medications and shrink it right down. So this patient was put on one of those medicines, and you can see how it got smaller. I think this is about 6 months later, right there. You can barely see it. Here's a patient here with, this is actually a young man with MEN1, and his first symptom of MEN1 were symptoms related to this large pituitary tumor. So this pituitary tumor is quite big, coming way up into the brain here. And here's the side view. So there's the forehead, the back of the head, the nose. Straight behind the bridge of the nose is the pituitary. But all of this that I'm outlining is tumor. So we call this a giant pituitary tumor. Again, it's benign, but these grow, and they can grow big. Fortunately, this was a prolactin-producing tumor, so we put him on that medication. And now you can see how small it is from the front view, and you can hardly even see it on the side view. So it responded and shrunk very well with the medication. The second most common type of pituitary tumor is a non-functioning pituitary tumor. So it's not going to make a hormone. There's going to be no signal that that patient with MEN1 has a pituitary tumor. And that's the reason Dr. Kennel, toward the end of the morning, is going to be talking about the type of tests we do to look at for these different components of MEN1 over time. And one of them would be a periodic head MRI scan to find these non-functioning pituitary tumors. So here's a painting a person. This person is facing this way. So the forehead would be over here. And here's a non-functioning pituitary tumor. And as they grow north, that's where they can cause trouble with vision. And here's just an MRI showing that. So here's the forehead here, the bridge of the nose. Straight behind that, here's that pituitary tumor. And we're only going to find that if we do periodic MRI scans. So those are the slides and images I wanted to share with you today. And I wanted to make sure to leave enough time for you to ask questions about MEN1 in general. As I mentioned, we have a whole lineup of other speakers who will be talking about the surgical approaches to various parts of MEN1. And then, as I mentioned, toward the end of the morning, Dr. Kennel talking about the kind of tests we do over time. But I'm going to bring the lights up, and please raise your hand if you have a question. So the question is, in that patient with a prolactin-producing pituitary tumor, this medication, there's two of them. One's called bromocriptine. Its trade name is Parladil. The other one is called cabergoline, and its trade name is Dostonex. And these act, they're similar to a hormone called dopamine. So dopamine in normal people keeps our prolactin normal. And in patients with pituitary tumors that are making too much prolactin, we basically give them dopamine at high doses in the form of these two medicines. And it hits a receptor. So all these endocrine cells have receptors, which is like a little socket. And let's say this is Parladil. It comes in and latches right into that socket, and it tells that cell, don't grow, don't make prolactin. Don't grow, don't make prolactin. So when that happens, the tumor shrinks dramatically, like I showed you in that young man, and it stops making prolactin. It only works as long as you take that medication, though. If you stop the medication, then the tumor would grow and make prolactin. So the question is prolactin what actually caused the tumor? So in the pituitary, remember we have these 6 hormones. They're all made by a separate cell in the pituitary. And what happens in MEN1 is because of the MEN1 mutation, any of those cells could turn into a tumor. So it's like one cell loses its good copy of the MEN1 gene, and then that promotes it to grow and divide, grow and divide, grow and divide, and eventually it becomes a tumor. So it depends what cell it happened in. And it might be in a structural cell, in which case it's not going to make a hormone, or it could be in that prolactin-producing cell. And if that happens in a prolactin-producing cell, It's going to grow, become a tumor. It's going to make the hormone that that cell would normally make, in this case, prolactin. So prolactin isn't causing the tumor, the tumor is a prolactin-producing tumor. So I gave you the example where the question is for acromegaly, what treatment options are there? I gave the example of a prolactin-producing tumor where the main treatment option is medication. All other pituitary tumors, we either observe them or we take them out with surgery. And Dr. Van Gumpel will be talking later this morning about the surgical approach to the pituitary. And you asked about acromegaly. The best treatment for acromegaly is surgery. We do have a couple medical therapies. They're injection-based medical therapies, and they're expensive, about $10,000 a year for the medical therapies. So if we could get a surgical cure, that would be preferable to medical therapy. So I'll take you through so the question is, radiation therapy is no longer recommended. The typical approach to a patient with a growth hormone-producing pituitary tumor, surgery. If we can't get all the tumor out with surgery, remember I showed you all those blood vessels and nerves on the side of the pituitary. If the tumor's in that area, many times it's not safe for the surgeon to go in there and try to dig out the tumor. So if we have some leftover tumor on the side, that's where we still use radiation therapy. Now, there have been some advances in radiation therapy, like gamma knife radiation therapy, which is this big Darth Vader helmet we put on a patient. Weighs like, a couple 100 pounds. So you're laying down. You don't walk around with this helmet on. And it has 210 holes in it, and each one has a gamma gun, and we aim them all at the same spot inside the head. So it's kind of like a magnifying glass, summer, sidewalk, dry leaf, and you can burn a hole in the leaf. Each time I give this example, the patient says, "Oh, the ants." I never did that. But it's the same concept. So we call that gamma knife. So if you have a small target, gamma knife works very well. If it's a big target, usually not gamma knife, usually more standard radiation therapy. Gamma knife is a one-day form of radiation, whereas standard would be a couple minutes a day, 5 days a week for 5.5 weeks. So the question is there any aggressive research being done to find medications to take care of? Oh, yeah. So basically, there's a lot of research going on each of the components of MEN1 that I've mentioned, because it's not just patients with MEN1 that have these tumors. These tumors occur independent of MEN1 also. So it's not just the 20 people out of 1 million with MEN1 that have these tumors. Many more patients have tumors like this. And there's research going on in all these to find better therapies, absolutely. So the question is MEN1 a genetic thing? And you gave a great example of your family tree with the multiple people that have it. So this is a genetic thing. And there's a presentation after the break from a genetic counselor, and she'll be talking more about the keys to genetic testing and things like that. But yes, this is a mutation in one gene, the menin gene. It's something we call autosomal dominant, which means if you inherit the mutation, you will have MEN1. And it means if you had 100 children, no human does this, but if you had 100 children based on odds, I mean, half of your eggs have the mutation, half don't, and based on odds, if you flip a coin 100 times, it actually comes out close to 50-50. So 50 children would have it, 50 wouldn't. But human beings don't do that, do we? So we have families of 1, 2, 3, 4, 5, and there's no way to know. It's like flipping a coin each time, which children will be affected by this gene. As I said, eggs, so it doesn't carry in sperm. I use the egg example because she gave the example of it's in her cell lines, and she's a woman. But yes, it's also transmitted in sperm. So This doesn't run with the sex genes, so to speak. That's what we call it. It's the other chromosomes, and they're the autosomes. So yeah. Well, somatic is a little bit different. Somatic means a mutation in one cell in an organ, whereas this is in the germline. So this will be in the eggs, this will be in the sperm. So the question is, what's the current protocol for children of individuals who have MEN1 in terms of determining if they've inherited the mutation? And again, there'll be a presentation on this. I'll give you a short answer, and you'll get an expanded answer later. So the advantage of genetic testing now is we can find the mutation, usually, in a family. And that's a very powerful tool, because then it's just a simple blood test. And then that can be done on anyone that might be at risk in the family tree of having MEN1, and you get a yes or no answer. If they don't have the mutation, they can't get any of these components of MEN1 I've talked about. If they do have the mutation, then yes, they're going to be predisposed to these components. Okay, so the question is, outside of genetic testing, what are the options? So this is what we did before we had genetic testing. As I mentioned, that the parathyroid problem, basically 100% of patients with MEN1 will have that. The sign of the parathyroid problem is a high blood calcium. So a very simple thing to do is just measure serum calcium. So it's just a blood test, you measure calcium. If it's normal, it makes it less likely that person has MEN1. It doesn't exclude it. And it kind of depends on the patient's age. Over here in the back. So the question was, I mentioned there should be monitoring for pituitary tumors. And Dr. Kennel will be talking about this, there's a couple types of monitoring. We do hormone monitoring, so periodic measurement of prolactin. There's a hormone growth hormone tells the liver to make a hormone called IGF-1. So we periodically would measure IGF-1. But because these tumors can be non-functioning, we also have to have that MRI. And you'll get a bit of a different answer depending which expert you talk to. I think a head MRI somewhere every 3 to 5 years makes sense, just as a screening for these non-functioning pituitary tumors. And these are in people with MEN1. So the question is, how rare is the Cushing's disease? So Cushing's disease is when, again, I'm talking about MEN1, where the cell in the pituitary that has that MEN1 mutation and loses its good copy is that ACTH producing cell. ACTH tells our adrenal glands to make cortisone. Cortisone is an important hormone. We all need cortisone to live. But if you make too much of it, then you get these signs and symptoms of Cushing's syndrome. Cushing's syndrome causes weight gain, causes rounding of the face. The weight goes into certain areas. It goes above the clavicles here. It goes in the tummy. In general, the arms and legs actually lose muscle, and the excess body weight doesn't go to the arms and legs. So arms and legs tend to get thinner, and all the weight's in the center. And then the skin gets thin. You can get the purple-red stretch marks. The question was, how common is Cushing's syndrome in MEN1? It's not very common at all. It's one of the least common types of pituitary tumors in MEN1. But it's certainly something that doctors think about every time we're seeing a patient with MEN1. And if we have a suspicion, we'll test for it. And we do have very good tests for Cushing's syndrome. So the question is, in a patient with MEN1 who's had Cushing's, what's the chance of getting a Cushing's back again? And what's the chance of having a different type of pituitary tumor? So the chance of getting Cushing's back again, and this applies to all people that have had a pituitary tumor making ACTH, not just someone with MEN1. Pituitary surgery is very good, but it's not perfect. The cure rate with the pituitary operation for that pituitary tumor making ACTH is about 85%. Then, of those cured, about 25%, there were a clump of cells that the surgeon didn't get out, and it slowly grows. So that person can get Cushing's again a year later, 5 years later, because of that little clump of cells that was left behind. So we call that recurrent Cushing syndrome. So it's not a brand new tumor, it's just leftover tumor that that patient had. So it's important to watch for that over time. And then you're right, that person's also at risk for having a brand new tumor that could make ACTH or could make norhormone or could make prolactin. So we think about those and watch for those over time. You're at no higher risk for getting a prolactin-producing tumor, for example, than any other patient with MEN1. Just because you've had an ACTH-producing tumor doesn't mean you're going to be a higher risk for getting a different type of pituitary tumor. So the comment is that you also had Cushing's. So we have, after I just told you how rare it is, we have two people right here who've had Cushing's related to MEN1. And you said your surgery was in 2005? This is 2014. That's great. So yeah, it would be unlikely that it would come back at this point. Once you're out there about 10 years, it makes it very unlikely. Yeah, good question. What's the difference between hyperplasia and adenoma? Hyperplasia means increased number of cells in general. It's just bigger because there's more cells. Adenoma actually is a tumor. Adenoma, that is a benign tumor, but it's a tumor. You know, there's two kinds of tumors. There's the malignant cancer tumor, and then there's the benign adenoma tumor. So it's actually a round tumor, whereas hyperplasia is just, you know, chunky, thick, lots more cells. Well, yeah, so there's a thought that adenomas can come out of a hyperplastic situation. Absolutely. Yeah, good question. So the question is, how do you detect bronchial carcinoid tumors? These are small tumors. And to be honest, when they're small and they stay small, that's probably just fine, you know. But if they're going to grow, those are the ones we probably should take out. So it's reasonable in patients with MEN1 to look at the lung periodically. And that might be, for example, a chest CT scan every 5 years is one way to think about it. There's another scan called an octreotide scan that can be done periodically that'll pick up carcinoid tumors. So the question is, the adrenal gland, I didn't mention much about the adrenal. I mentioned, you know, in that overall scheme where patients with MEN1 can get a benign tumor of the adrenal or thickened hyperplasia adrenal glands. And fortunately, these usually don't make excess hormone, so usually we don't have to address it surgically. There's a different type of multiple endocrine neoplasia that I didn't talk about, but you're going to hear a little bit more about today, called MEN2, MEN type 2. And with MEN type 2, they get tumors in the inside of their adrenal gland that's called pheochromocytoma. And that does need to be approached surgically. But in general, in MEN1, when we see that adrenal nodule, it's a benign nodule, and as long as it's not making a hormone, usually we leave it alone. If it gets real big, or if it's making a hormone, then we would take it out. And you will be getting a discussion from Dr. Farley on adrenal surgery, so he'll be talking more about that too. So his comment was that he had an octreotide scan, and that he was told that this would identify neuroendocrine tumors related to MEN1, and also that he understood that this is also being looked at as like the silver bullet, and you could attach some toxic things to octreotide, and it would take it to tumors. So this octreotide scan, it's called octreotide scintigraphy, is based on a hormone called somatostatin. Turns out many endocrine glands and many endocrine tumors have receptors. Remember I talked about that receptor where things lock into it, like a docking station? Many hormone-producing tumors have receptors for somatostatin, which is octreotide. So you can label octreotide with a very safe nuclear substance, and you can do a scan. So the scan's usually done in a nuclear medicine department, and it can identify, and it looks at the total body, if there are spots that are hot. And that tells you there's probably a neuroendocrine tumor there. So yes, periodically we'll do octreotide scans for that reason. Then your second part of your question is, can that be used therapeutically as a treatment? because I told you that we label it with a very safe radioactive substance. What if we labeled it with a toxic radioactive substance? And that's been done, and there's ongoing research on that. There's some problems with that, because if I were to show you octreotide scans, you'd see that normal structures light up with octreotide too. So it doesn't just go to neuroendocrine tumors. So when we do label it with these more toxic radioactivity, it gets taken up by the kidney, for example. And so when we've done this, and like you said, in these experimental procedures, you can get some toxicity to the kidney, and the kidneys don't work as good after you've done this treatment. So this is not something that we're offering right now as a treatment. It's something that, as you said, is being investigated and looking for ways, how can we make that really more selective, just to the neuroendocrine tumors? But that is something that we're working on for the future.